And
Okay.
we're live.
All right. Thanks, everyone, for bearing with us. Slight technical interruption, so apologies to everyone who has taken the time to view this. We appreciate your patience. Next in our speakers is Juhan Sonen, who is my partner at Involution Studios. Juhan specializes in software design and system engineering. He operates and is the director of Involution Studios, which is a UX firm designing the future of healthcare. Juhan is going to talk to us today about care plans, a path to driving better outcomes. Juhan, thanks for being with us.
Okay, thank you, John. Let's get right to it. So I have a dual life. One life I live at an institution in Cambridge, a technical institution, teaching engineering design. The other is failing to run a design studio where I think about 150 million people use the software that we create. It just happens to have someone else's name on it, where we concentrate on open source health and big healthcare system engineering. Feel free to yell at me, whether it's publicly via Twitter or via email. I'll try to get back to you within 2 business hours. I highly recommend downloading the presentation at your own leisure. You can fall asleep to it at night at this URL. Our tribe here has spent some time thinking about how to engage actual people to behave healthier. Typically, they're either applications for caregivers, their loved ones, care navigators, portals, God forbid, or patient-facing, clinician-facing mobile care plan apps and services for things like diabetes and hip replacements and all sorts of fun goodies. Now, this research has been informed by these fabulous folks here, and let's get right into what the heck are care plans. Well, they are, in a nutshell, a holistic view of all of your plans of care. All the data should be there across your healthy life, and it's driven by you and the cohorts that you assign to your care team that are maybe not assigned by birth, and it's evolving. It is ongoing. So the care plans may contain, usually they do, a high-level patient summary. Who the hell are you? Why are you here? And in terms of your why are you here, the health concerns, your why are you having an issue? What are your goals? What are those interventions, those micro nudges, the behavior shifts that you need to do, and how do you do it? And then a feedback loop in order to say, okay, am I progressing or regressing? And then there is, of course, the care team across the spectrum of health, whether it's your clinicians, your RNs, your family, your friends, your proxies, that engage with you to get better or healthier or stay the same. So let's set the stage a bit that care plans in the current landscape, they don't really exist in today's practice yet, and that's sort of sad. But let's look at it through the eyes of Edwin here, who's broken his leg and now went to the ER about a week ago, and now he's seeing his PCP, his primary care doctor, and he had trouble getting a hold of a doctor in the first place. It's a separate problem. And then, the doctor here, has a lot of problems just getting his health records sent over from the ER, and has to rely mostly on verbal accounts from Edwin. And so there are no standard communication tools across these institutions. And because the clinician doesn't have the whole story, she has trouble working out what's the right care plan, right? She might ask certain questions to Edwin. He may understand them or forget, or, it's not by on purpose usually, but omit information. And then, Edwin is concerned about, potentially his privacy. What will people see? I have other kinds of care plans or care needs in my life. So then, as a typical problem in healthcare as well, is this episodic treatment, right? So that maybe the clinician tells Edwin to come back in a month, but that health status could change drastically in that time. And if he follows the same tidbits of advice, it could be detrimental. And then, after Edwin leaves the office, this is a familiar territory for many of us, is that half of people actually comply with the prescription if they need it. And so there's, like most people though, Edwin doesn't want to think about his health. So there's this idea of noncompliance, which is just built into us as humans, unfortunately. And unless a care plan is designed in an accessible and engaging way, it probably won't be followed outside of the doctor's office. Now, this is like the current clinical standard of providing a care visit and visit summary. It's not too effective. This is actually Beth's real life visit summary from a real life doctor's appointment with a real life care plan. Woohoo! This is amazing. But, it's not surprising. And the thing is, we have to also not put all of our eggs in one basket, so that only 1% of your care happens at the doctor's office, and the other 99% happens outside, is up to you. So how do we create these health interventions that stick? And another final, swath of the problem today is that MDs don't scale. Sorry, Joyce. Like it's great that I know you, and that's a great scale problem because I know several doctors, but most people do not. And so we know that the need is going to be there and going to continue to increase. Now, there's been a small tick in this, and there's actually a CCM code in 2015 that came out that allowed virtual and actual care plans to be applied to Medicare patients. So once these models are proven, I think you're going to see more and more of this hit preventative care. Now, we have a huge list of care planning services and remote care services on the site, so I highly recommend you parsing through that. But I'm going to sort of go across that because this is more bedtime material to go look into what needs to be thought about when we design for care plans. One, sounds obvious, but it needs to be said, is that we have to start by giving patients a care plan, because 90% of the time they don't get one, and you got to start there. Number two, you need to determine the current state of the patient and the desired outcome. So whether it's using techniques like motivational interviewing to understand the intention, you have to sort of design and get these tiny habits and understand what triggers people. Because the process is pretty manual now, but ultimately we want this to be automated in the future, where the bots and humans collide into something that I can actually use beautifully. Now, we also want to make sure that when we're getting inundated with disparate data, whether it's your sleep trackers, your monitors, your body temperature trackers, whatever the scales are, that you're monitoring relevant health metrics and that we're seeing progress towards specific goals. So it's mostly irrelevant data that we're getting now and a lot of effort. We need to inverse that, because look, over the next year, I think next year 20 million people will be remotely monitored. And that's pretty fantastic. Yet, what are we doing with that? How are we involving your brain cells in a different way, not just here's the data? So you have to be able to go beyond just capturing the data into doing something more important with it. What am I going to do with it? What's the behavior triggers in order to get you there? Sort of crazy, but that's a key part of storytelling. And here's a couple ways to see that, whether it's in a simple asynchronous text, seeing the traverse over time, what should I do? Now, you also, in that same vibe, need to see history over longitudinal period, over time. Health happens over time, and we as a species are not very good at seeing it. It's hard for us to see week by week changes in our body, but we need to be able to see trends. You need to be able to collect the stories in order to make better predictions. Here's the more geologic view of my health, one take at it, but there are many of them that we need to sort of look at and design. Next, you need to look across the entire care team and collaborate, for God's sakes, on the patient's health needs, and try to be as synchronous and contextual as possible, driven by the patient, the human, and their navigators, right? The people who sort of help shepherd them through life. Now, this care plan should tap into all these levels, these different the Dunbar numbers and variations in someone's life, because it is essential to include this kind of education about how to collaborate and how to influence outcomes. So, one possible way is, whether it's a FaceTime in this example, but I use Sherpa, and that's an asynchronous way to communicate with a clinician in this, and I've used it as recently as this week. asynchronous seems to really, really easy way for people to communicate, whether it's their doctors or their kids. And also, you need to give control of their care plan, to the patient, that is. Because sadly, the patient doesn't own their health data. Only in one state today, and the law in New Hampshire is pretty mediocre. And I think this is critical for in the future that I own it, and it's not just stewardship. There's a big difference between those two words. So let's look at care plans in the future. To wrap up here a bit, so as we start to shift more towards an organized population efforts like PMI, Precision Medicine Initiative, we are going to develop systems that pull from national standards. We don't have any national standards for care planning, or even for our data for that matter, that are informed, that drive our evolutionary care plan based on a populace as well, not just our own. So I see this by, there are different organizations working on this, like Beyond Health or the nonprofit MITRE and others that are working on evolutionary care planning or intervention engines. And, we as humans are really distracted by everyday stuff in order to, recognize poor health patterns and then identify the right ones. We're not good at it. So in order to reach those outcomes, or at least come close, to fine-tuning ourselves, we need to, get all of our care team involved, and we have to utilize technology and policy and culture jamming to educate and empower people to take control over their health. So in review, I mentioned 7 principles here, and it's a central foundation, right, to implementing each of these. And so the next part, I think, is critical. It's the underlying component to all this is personalized education at the right level, in the right way, at the right time. So this is just a start, and I think at the primordial start to getting a care plan is getting one in your hands. That is the first huge step, is what is that care plan? What is the standard of care? What do I have to follow? And then we can start to map on the rest of what we just talked about. I would like to thank very much my fellow co-authors, people who gave feedback to it. And with that, I'll move on to my own little care plan here. And if you have any questions afterwards, fire away.
Thanks, Johan. Just a reminder, if you do have questions for our presenters, just hashtag DesignDH on Twitter, and we will be reading those questions at the end of the presentation. So thanks a lot, Johan, for that presentation on care plans. And batting cleanup today is Joel Schwartz, who is a technologist focused on improving patient experiences with enhanced comfort, education, and joy. Joel is the CTO of Sproutel, which is a patient-centered design and tech company that created Jerry the Bear, an interactive companion for kids with type 1 diabetes. Joel concentrated in engineering at Brown University, and when unplugged, you can find him fly fishing. Joel, thanks for being with us today.
Thanks, John. So I'd like to talk a little bit about some of the lessons we've learned at Sproutel while designing in pediatrics. And just to open with this quote from Seymour Papert, "I'm convinced that the best learning takes place when the learner takes charge." This idea of learning through doing, and that the best learning takes place when the learner is really engaged in the process, is something we believe absolutely applies to healthcare, absolutely applies to kids' health, and is really important to consider as part of the process designing for kids. I think this echoes comments already from Joyce and Johan, that when kids are engaged and have a feeling of agency in their healthcare, they have improved health outcomes. So here's the golden question: how do we use design to help engage kids in their healthcare? Well, there are many great examples outside of healthcare about products that do this really, really well. And they do it, we think, by appealing to the love that kids have for story, by appealing to their imaginations and their creativity. And there's a huge range to this. Some toys like My Little Pony and Barbie and Transformers provide a storyline for kids to become absorbed into and extend and co-opt in their own way. And then there are other toys and platforms like Lego and Snapchat that kids can use their imaginations to build something and share it that's entirely their own. So all of these toys hold kids' attention because they reach kids on their level, and they appeal to the love of story that kids have. I think this is like some very valuable insight that we can extend into healthcare. But when we look back at a lot of resources that are used in pediatrics, and these are some dated examples, we see stuff that doesn't really engage kids. And historically, there's a great reason for this, especially in cases when resources are limited. In pediatrics, especially for really young kids, parents are a key care provider, so there's a huge and necessary emphasis on reaching parents first. But the kind of unfortunate side of that is that there's like this pass back of whatever's designed for parents gets turned into a kid version, which usually means paper pamphlets, paper brochures, stuff that doesn't really capture kids' attention, and healthcare becomes talking at kids rather than talking with them. So there's this great opportunity to engage kids more in their healthcare by appealing to their interests and talking to them at their level. And the need is enormous. These are large and growing numbers of populations with serious diseases. So it's really important that we start designing directly for kids. And to do that, we start with this kind of foundational question. What are children seeing, what are they thinking, and what are they feeling as they experience healthcare? A design tool we rely on at Sproutel to go through this are patient journey maps. This is formative research that we do at the beginning of a design process. It's the culmination of interviews with kids, with their parents and their providers. This is an example of what children are experiencing in type 1 diabetes, beginning with diagnosis all the way through some self-treatment milestones. And we build these patient journey maps for kids, for their parents. And after we've done this a number of times in a few different diseases, we start to see three key kind of trends and three key criteria that we've adopted as design criteria when we work on solutions. And these are comfort, education, and fun. Comfort, importantly, because healthcare can be very scary for kids and parents. Scary, confusing, it's stressful. There are a lot of changes that come from a new diagnosis. And we think that comfort really helps to bridge that gap between being afraid of your diagnosis to feeling you have agency and control over your healthcare. Education, of course, because there's a lot of very complicated, necessary information that needs to be transferred from the medical expert to the parent and the child. And even before, in pediatrics, like young children, even before those children start practicing self-treatment, even having some foundational education about what's going on in their care really gets them to be more of a participant, gets them to be more cooperative and more compliant. And then fun, obviously, we're designing for kids, so we have to talk to kids at their level, and just because something is serious doesn't mean that it can't be fun. So to use our flagship product as an example of our design process, this is Jerry the Bear. We designed Jerry for children with type 1 diabetes. And before we got started, we had a lot to learn. So we built those patient journey maps I just showed you. And really importantly, we conducted these interviews with kids and their families in the context of their home. And we did these interviews in the home because we wanted to build a product that reached the family in the home. And so while we were doing this, we found some really cool insights that a lot of children were playing with their stuffed animals as if they had diabetes. They were taking the care that their parents were giving them, transferring it with their imaginations to an object that gave them a lot of comfort, and this was our light bulb moment. We thought, what better way to engage kids than the way that they're already engaging with their healthcare? So we set out to build Jerry the Bear to bring this insight to life. Here's a picture of the first bear we made. It's a little bit rigid. The moving eyes maybe were a little more creepy than playful, but amazingly, kids still liked it. It was a really encouraging start for us, and as we kept iterating with our designs, we continuously tested with kids. Here's Hannah, our other co-founder and chief creative officer, in full bear suit, talking to kids at their level and getting user feedback with an early prototype. And we took that feedback, we held design workshops where kids directly answered questions like, who is Jerry? Where does Jerry come from? What is Jerry's school like? Who are Jerry's friends? And as we repeated this process with kids, we built over 29 prototypes, tested with about 300 kids before we finally arrived at we were ready to launch as the first version of our product. So we landed on an interactive bear. Kids can check the blood sugar, feed a variety of food, provide Jerry with insulin, and a series of animated storybooks that kids helped build, which give not just Jerry's origin story, but a vehicle for us to give this curriculum about type 1 diabetes. And all of these interactions were tweaked and tuned along the way with a balance of feedback from parents and educators. So what we think is really powerful is that the result of this patient-centered, iterative design process was that when we were ready to launch Jerry, we had some pretty good indication about how it was going to perform. But we were really blown away by the result. A few weeks after we shipped the bear, parents started emailing us these photos, posting these photos on Facebook. And all of the testing we had done, we never would have expected that Jerry would have gone to bed, like kids would be cuddling with Jerry at night, that Jerry would be the first thing that kids grab when they need to explain diabetes to a friend, that parents would be setting a spot at the dinner table for Jerry. And we think that the way that Jerry transcended what a typical toy might do is because kids co-opted Jerry's story into their own. Jerry tapped into something, the kids' own story about what it's like for them to go through healthcare, for them to go through their experience in type 1 diabetes. And this is the real power of including kids in the design process and designing in the context of the home. And there's some really cool examples, and many more than are on this slide, of other products in healthcare that do just this. So Sesame Street, not just in healthcare, but we look at this as like the epitome of great design for kids. And the result of their laser focus on designing with kids and engaging with kids has been decades of super high quality content that has like set a benchmark for the outcomes you can achieve in school readiness and health education. Other companies kind of inspired by this are Health Notes Media and Tiny Docs, who are replacing some of those paper pamphlets in hospitals and doctors' offices with more engaging animated content. And then on the spectrum of comfort and fun, we see things like stuffed animals, Rufus the Bear and Lenny the Lion, which are stuffed animals designed for kids with type 1 to talk about injection site rotation. And then on the fun spectrum, there's Nintendo's Wii Fit that gets kids engaged and active through gameplay, Toca Boca Monsters Kitchen, where kids explore what it means to cook food and nutrition by feeding these imaginary creatures, and Remission, which is a video game for kids with cancer. And just to talk a little bit more about Remission, because it's such a great case study of another dimension to designing with kids. This game comes from Hope Lab, and is a game where kids play inside the body, blasting away at cancers with weapons like chemotherapy and antibiotics. The game was designed by a team of video game designers, health psychologists, and cancer researchers to address the problem of non-adherence to cancer medications during remission, which can put patients' survival at risk. So the goal of the game was to educate and motivate behavioral change to improve treatment adherence. The diverse team that Hope Lab assembled to do this made for a very cool collaboration, but also a tough one. There's a balance between the different stakeholders in this design process. How creative and entertaining the game might be to achieve what the video game designers were trying to create, to capture kids and pull them in. And then how literal and explicit some of the education needed to be to meet the standards of medical experts to make sure that things were being explained correctly. But what Hope Lab did is they anchored their process to the child. They said that the key objective was to engage the kids and to make sure that no matter, like above all else, that the kids, how the kids perceived this was a benchmark that really aligned the entire team, was able to kind of cut through and provide something for everyone to focus around together. And we think that's really important at the way that including kids in the design process can be a great mitigator and also for better alignment on how to build these products. The result was a game that kids really loved, and it absolutely achieved some of their goals. Here's a quote from a 13-year-old survivor and remission player who says, "It feels like you're succeeding in your treatment, not just sitting around wondering if it's working," which is exactly what they tried to achieve. They were able to improve adherence because they helped kids, they spoke to kids at their level and helped them understand what the purpose of taking this medication was. So these points very much echo what Joyce and Johan said already, but for us, the key takeaway of this talk, remember one thing, remember that kids have a critical role in the design process. Kids are creators, they have awesome creativity, and they're wonderful to work with. They're also a great mediator when balancing needs and desires of different stakeholders. And when you design with kids, you can build a product that creates really awesome engagement. And if you remember two more things, the second one is that play can be used to give kids agency in their healthcare, which leads to improved outcomes. And the last one is that it has to be fun. Kids need to be engaging with something in order for it to be useful. They need to use it. And fun is a great way to capture that. Thank you.
Thanks a lot, Joel. So in consideration of our earlier technical difficulties, Dr. Joyce Lee has agreed to give a shorter version of her presentation. I think our live stream went down right in the middle of Joyce's presentation. Apologies for that. Google live stream just disappeared on us. So Joyce will be giving an abbreviated version of her talk on patient experts, digital technology and the maker movement for the folks who were unable to see that. Thanks, Joyce, for your sense of humor about this and for doing this again.
Okay, can you hear me? Okay,
Yes.
so I'm going to do this quickly. So, father of patient with type 1 diabetes uses the CGM, but wants it to go to the cloud, but there's no mobile technology solutions. So he actually programs, hacks into the CGM and develops his own solution to get it to go to the cloud, the numbers, and then develops wearable solutions like Pebble watches, mobile technology apps, and desktop apps. So it really just ends up spawning a kind of revolution inside the diabetes community because there's other caregivers who say, I want this technology, why can't I use it for my kid? A lot of people start doing collaboration and open source code, and then they realize this is so beneficial that they want to share it with the larger community. So they open up a Night Scout website, so it's nightscout.info. They provide all of the information about how to set up the system. They provide the open source code so anyone can use it, modify it, morph it. And then they create a Facebook group called CGM in the Cloud, which now has about 20,000 members, plus it has a whole bunch of offshoots in international countries. But basically what has happened is that the Facebook group is now like a geek squad where people can go and get advice from others in the community about how to set up the systems, troubleshooting, as well as sort of sharing new innovations. So what do we know about mobile technology in this community? One is that a lot of the users for this are actually kids who are wearing the device so that parents can kind of keep watch over them. We know that, for example, kids are using it for nighttime school, sporting events, and travel, whereas adults are using it for nighttime sporting events, travel, and work. We see that there's a huge number of different types of caregivers that are doing sort of that are carrying devices to watch blood sugars of an individual child, for example. And then what we are seeing inside the community is a bunch of interesting new visual prototypes, which is, I think, what's most fascinating. I sort of see these interfaces as, you know, the future enterprise solutions that have yet to be developed inside the sort of more traditional channels of healthcare technology, whether that's the device companies or the healthcare delivery systems. But essentially, individuals are creating all sorts of new ways to look at data, like ambient awareness of blood sugar. So it's the bus schedule, the temperature, the blood sugar, and the time that goes. It's sort of just a different way of thinking about how to monitor blood sugar. There's individuals who are making Apple menu bars, solutions with Alexa, and then individuals are also developing their own hardware solutions. So for example, they're developing their own kind of receivers to capture CGM data from sensors. So kind of almost recreating the hardware solutions and then also developing artificial pancreas solutions. So I think the point that I'm trying to make with all of these different solutions that exist is, one, this is really important, this idea of patients as makers who are sharing all sorts of interesting tools. They're sharing them open source. It's allowing for modularity. It's allowing for remix and resharing. And I think it's a really powerful way to sort of think about users as designers. As I mentioned before, this whole concept of meta design, like I think generally the further we move towards users, the better we will be in terms of having the most innovative and useful solutions. So my kind of takeaways are that, one, really important to learn from patient and caregiver innovations that have been created. There's a ton of DIY solutions that exist on social media otherwise by individuals who are living with disease. Two, I think it's actually really interesting to think about the maker movement as a model to sort of help create or help patients and caregivers be creators of solutions, sort of plug and play, kind of like Scratch. And then three, really, really important to let patients and caregivers design, because and most importantly, define the problems that need to be solved. Because I think, again, often in healthcare, we tend to focus on the wrong problem, which leads to the wrong solution. So I just want to thank my collaborators from the community as well as our research team. And that was sort of the abbreviated version. Thanks for giving me the time to do that.
Yeah, Joyce. Thanks for doing that. So one of the questions I had was, Are there any scenarios where these patient maker communities run afoul of some of the regulations, whether it's from FDA or just other regulations that are part of the healthcare system? I would think the DIY ethos is not that definitely butts up against sort of the regulatory standards that we have so many of in this country.
Well, what's sort of interesting is FDA is certainly aware of the group, but my understanding of FDA is that it really regulates commerce, and this is not commerce because this is individuals who are kind of distributing educational tools that might help them manage their diabetes. Do I personally, as a physician, prescribe Night Scout? No, I don't think I can do that because it's not an FDA-approved device. But if an individual discovers the community and finds that the tools are useful and finds a community of individuals who can help them set it up, I think it's interesting because what it provides is an opportunity to do sort of self-management bottom up instead of top down. And I sort of think about the maker movement as a really interesting way to sort of re-envision kind of community-based making for health, which might be totally different than what we think of, which is healthcare delivery system designed this for the patient. So I think bottom up is much better than top down. I think that there's questions about efficacy and safety. I think the patient community, so for example, in the case of artificial pancreas solutions where there's delivery of insulin, there's certainly a lot more risk, but the idea is that most individuals build it themselves. So 1, they understand the diabetes better. 2, they understand how it was set up. And 3, they can understand where the kind of risk is. And so in a world of fax machines and sort of answering machines, I can hardly sort of blame the patients for having to design their own solutions because what they have right now as standard of care is so suboptimal.
Yeah, that's definitely an interesting movement to keep our eyes on as we watch how digital health develops and patients also become designers. Thanks so much, Joyce. So we're going to wind up our presentations for today. Thanks for sticking around for the duration. We're just about out of time, but if you enjoyed the presentations you saw for designing in digital health, this was our first our prototype, and the second Designing in Digital Health is planned for February in 2017. So we hope that you might come back and join us for that, and we'll be releasing the speakers for that event in early January. So thanks again for joining us for Designing in Digital Health. We appreciate you attending today, and we hope you have a great remainder of your day. Take care. Bye-bye.